Okay. So meanwhile, I'll just take you through the introduction. I'm Dr. Neha. I work at Manipal Hospital as infectious disease consultant. You have been hearing a lot about how do we manage things in ICU so far. But today, now, for next 10 minutes, if I get so, you'll have probably a jam session about what to do with the antibiotic resistance that we all might have been facing in our ICU or ward setups.
It's on.
All right. And it moves. Okay. So, yeah. My topic is role of antibiotic rotation in management of sepsis. Antibiotic rotation is not something very conventional that we do or follow in our setups currently. Although it is something that has been talked about or explored as an option to reduce MDR resistance for quite some time, as as early as 1985, and you can find studies dating back 1981 as well. So what does it basically do? It rotates. You rotate the antibiotics, use one particular set of antibiotic, and then don't use it for another duration of time. It is like rotating a crop where you try not to use certain crop for a very long time just because it may get infested by pest. So we all know that the recent 2020 ICMR surveillance showed that we are dealing with quite a bit of carbapenem and ESBL resistance. ESBL resistance in India is as high as 70%, and we know that carbapenem resistance is nearly about 80% in Acinetobacter, 55% resistant of Klebsiella pneumoniae, and E. coli has been nice so far. It is only 28 to 30% resistance has been seen for imipenem, that is a carbapenem in our setup. So this surveillance was done across around 14 Indian setups, and still we found that much resistance. Then that's quite a bit of resistance for carbapenems. We know that we are running dry on the tap of antibiotics. We don't have many options as far as antibiotics are concerned. Hence, we really need to use them judiciously. They spread through several ways, several modes, several methods. And one of the major risk factor for increase in MDR resistance in ICUs or in any clinical setup is utility of or prior use of antimicrobials. So there are other factors as well like age, and I will not be discussing about that, but one of the most common factors that leads to antibiotic resistance is probably antibiotic prior therapy. So what does this antibiotic rotation ponders upon? We actually believe that antimicrobial products which are used to kill, they or significantly slow down the growth-causing microbes. Under certain conditions, the selective pressure drives the evolution of mechanism that allows some microbes to resist this particular activity, wherein they will try to survive more, and then resistant microbe will become more in number and they'll thrive better, and they will become the predominant flora of the place. So this occurs when there is a pressure of an antibiotic in particular setup, and then only this particular concept comes into the picture. Cycling is the scheduled rotation of one class of antibiotic with one more different class exhibiting almost comparable spectrum of activity in order to fulfill the definition. And there has to be complete cycle. So when you use one, then you don't use one, and then you again use the similar one. There are other strategies like antibiotic mixing as well, which is, antibiotic rotation is rotating antibiotics, while mixing is you use appropriate antibiotics and you allocate them to the patients randomly. So there is no homogeneity in that. It is more of a heterogeneous approach, while rotation is more homogeneous approach. So this is just an example. How do we achieve antibiotic cycling or rotation? So if you can use a quinolone, then you can use a cephalosporin, then you can use a beta-lactam, and then again repeat the same cycle. Then similarly, in scheduled antibiotic, you can use a cephalosporin, carbapenem, cephalosporin, beta-lactam. So this is what is rotation. Then in mixing, you can use cephalosporin, carbapenem, then you can randomly allocate anything to anybody. That is what mixing is. So they believe that mixing actually reduces the risk of over-utility of one particular antibiotic. So as I said, the the studies for this particular purpose has been done from very long time, but none of them have been found to give us a very um, strong data. So this is one data which was actually published somewhere in 1990. It showed that before the period of antibiotic rotation in the ICU setup, there was the VAP mortality was around 10 to 12%, while after a period it dropped down to 6 to 8%. And similarly, in the bloodstream infection also, the mortality difference was quite significant. These are certain studies which are from different decades, just to show that there have been mixed type of results while using antibiotic rotation. So they did see some benefit in several studies. I've just quoted few important ones, not all. There are almost 40, 50 studies that you can go through if you go through the literature of antibiotic rotation. But the few one which I have put in here, some of them use cycled, some of them use rotated, some of them use mixed. But the thing is, they did not get a consistent result despite doing all these things. So they did find some benefit, and the reduction in the resistance of that particular organism for that antibiotic for some time. But then, as soon as the rotation was stopped, there was again the resistance creeped up again. Now, this is an important paper which was published in 2018, which I'm not sure if it is visible, but it was done across 38 ICUs, and they tried to randomly assign the ICU to mixing and rotating, and they did not. In the cluster randomized crossover study, around 8 ICUs, the 9-month period of antibiotic cycling and missing did not change the unit-wide prevalence of antibiotic resistance in the GNBs. Therefore, the structured rotation, as per this particular study, did not have a very good outcome. Similarly, this PLOS-1 study was published in 2022. It is quite a recent data, and this is known as Saturn study. They again said that there's not much benefit, and they did not support superiority of cycling over mixing, and rotation should not be the standard of care when used in ICU setups. So, yeah, skip that. Now, authors from several studies basically have concluded that there are no benefits of antibiotic cycling, rotation, or mixing, and leaves us very small window for future research. But is there still a hope is the question that we all have to ask. And while the 2018 study in Lancet was published, this was the editorial on that which went, asking that is it too early to pull on the plug? So suppose hypothetically I do say that I want to use cycling in my setup, and while going through the data, what did I see that will still give me hope to use this strategy in my setup? See, whenever they try to use this particular setting across several institutions, they failed. So I think when the data is read very carefully, you can still find some benefit of having this particular strategy utilized in a single setup where you know your antimicrobiogram very well. Hence, then you can utilize it better, and then you can isolate the drug which you have to do and do it further. So I think this still leaves us with a lot of questions. See, resistance is not something that happens due to single strategy, due to antibiotic pressure. That doesn't always works like that. It can be due to several things. It can be plasmid mediated, it can be intrinsic resistant, it can be n number of things that can lead an organism to become an MDRO. So can we make this particular strategy as a single sole strategy to prevent MDRO? Probably answer is no. Can antibiotics that have been withdrawn from the usage because of higher increasing rates of resistance to them be reintroduced without leading to re-emergence? So I don't use one particular antibiotic and then I reuse it. Is the answer that I will not get the resistance to that antibiotic? Answer is again no. Maybe I'll get it, so I have to keep doing this process over and over and over again, so to get through this. Is it possible to replicate this in Indian setup? I mean, I was talking about 80% Acinetobacter resistance, which is quite a huge number. And when we are seeing about one option or two options among the antibiotics to treat this particular or any particular infection, what do we rotate it with? Do we actually have options to rotate these antibiotics with any particular thing? Again, this is something that has to be pondered or thought about. So I think solely alone it may not be the strategy that may work. Reduction of total volume of antibiotics that we use or that we prescribe, cutting short on duration, following a proper antimicrobial stewardship program should be the strategy. We have to strengthen our basics. We have to, follow that hand hygiene, environmental disinfection, chlorhexidine baths, correct type of precaution while handling your patients, cohorting the MDROs if isolation is not possible. It is quite impossible in Indian ICUs. I'm sure everybody's struggling with that because probably half of our patients are either colonizing it or are having infections with MDROs. Then AMSP, antimicrobial stewardship program probably holds a good, it is something alone I think that may form a good basic on prevention of MDR bugs. But again, it's a difficult to perform things in, especially in the smaller setups. So I think I have finished things on time. But to summarize, data does not show any benefit of antibiotic rotation in ICU setups. We may need more data, especially in Indian setup, to kind of consolidate this. Whatever we have are crossover studies. They are all done in European setup. They have better bugs than we do. They have better drugs than we do. They have better antimicrobial stewardship programs than we do. They have better auditing of antibiotics than we do. And they also follow the, other antimicrobial stewardship things much more religiously than we do. So can we replicate it in our setup? Answer is probably we have to consolidate and do it and then see and come up with an answer to that. But as of now, we don't have any Indian study supporting this. It can be used as an adjunct to other general measures that we follow in control of MDR infection, but as a standalone strategy, it may not work. You have to combine it with other antimicrobial stewardship things or other strategies that we apply to prevent MDR bug formations in our ICUs. A good AMSP could be an answer. I heard a lot about, 1 hour bundles and other things. I do get it that it is important when patient is in shock, but I still think that antibiotics should be judiciously used when the patient is not in shock. Hence, I stop my session here. Thank you for having me. And I would like to thank JCS for giving me this opportunity. I'll be happy to take any question as
No.
I do have 2 minutes. Yeah.
Thank you. We'll take up the question at the end of all the speakers.